Hello everyone, my name is Alex Gordon, and for this edition of the Skull-Based Oncology case series, I'll be discussing sinonasal glomangiopericytoma. A 73-year-old male with a known pituitary microadenoma that was stable on the last two surveillance MRIs presents with an incidentally found asymptomatic right sinonasal mass. The patient denies any history of sinus infections, pain, epistaxis, vision changes, nasal drainage, or nasal obstruction. He also denies a history of malignancy, radiation, or previous nasal or sinus surgery. He denies smoking and heavy alcohol consumption. On physical exam, a solitary flesh-colored right nasal mass was seen medial to the middle turbinate, which extended superiorly and posteriorly. The left nasal cavity, pharynx, and larynx were clear. There were no cranial neuropathies observed, nor were there any neck masses or lymphadenopathy. Non-contrast head CT showed opacification of the right ethmoid bulla extending to the superior medial nasal cavity. There was also focal dehiscence or thinning of the right fovea ethmoidalis. Similarly, MRI showed an enhancing expansile lesion involving the right ethmoid bulla with extension to the right superior medial nasal cavity. The mass contained an intracranial component which extended through the cribriform plate and fovea ethmoidalis, and it measured 1.4 by 0.9 centimeters. A biopsy of the mass was obtained, which showed neoplastic proliferation of plump, relatively uniform spindle cells, without mitotic figures. There was also weak immunostaining for smooth muscle actin, and negative immunostaining for several other markers that were assessed. Ultimately, the mass was diagnosed as a sinonasal glomangiopericytoma. Given the radiographic confirmation of cribriform plate involvement and the lack of nodal disease or distant metastases, the mass was staged as a T3N0M0 sinonasal glomangiopericytoma. Sinonasal glomangiopericytoma is a rare, indolent vascular tumor of the respiratory epithelium. It was renamed in 2005 from sinonasal type hemangiopericytoma due to its pathologic resemblance to glomus tumors. It's thought to represent less than 0.5% of all sinonasal tumors, and it has been reported in all decades of life with a slight female predominance. There's no clear etiology of this condition, but trauma, hypertension, and corticosteroid use are predisposing factors. This condition commonly presents with epistaxis, nasal obstruction, and headache, though advanced cases may present with facial pain, bulging, and proptosis. Because of this, cases of misdiagnosis as benign nasal polyps have been reported in the literature. The treatment of sinonasal glomangiopericytoma is relatively uniform, consisting mainly of total surgical resection. This is most commonly done via an endoscopic approach, though in certain advanced cases an open approach, including partial maxillectomy, has been reported. Chemotherapy and radiotherapy are less effective for this tumor and are reserved for recurrent disease or palliative therapy. Due to the vascular nature of this tumor, preoperative endovascular embolization has been reported in several cases. In some cases, this is achieved via transnasal injection of a liquid polymeric agent. This is not currently standard of care, and there are not yet strict criteria for preoperative embolization. Patients who undergo surgical resection of sinonasal glomangiopericytoma generally have a good prognosis, with negative margins achieved in 33% of resections. As many as 20% of these patients, however, will experience recurrence after surgery, and up to 40% of recurrences occur more than 5 years after surgery. In spite of this, there is a 5-year overall survival rate of 90% and a 5-year disease-free survival rate of 75%. One systematic review of more than 300 patients with sinonasal glomangiopericytoma found that positive immunostaining for CD34 and negative immunostaining for actin were associated with improved overall survival on both univariable and multivariable analysis. The same review found that younger age and right-sided tumors were associated with improved overall survival on univariable analysis only. The management of recurrent or metastatic disease typically involves chemotherapy. While there are many regimens that have been used for this purpose, those based on adriamycin have shown the best results. Radiotherapy has also been used for this purpose, as well as an adjuvant therapy in cases of incomplete resection. Our patient underwent an uncomplicated endoscopic resection without preoperative embolization. The tumor was found medial to the right middle turbinate, transgressing the cribriform plate and dura. The intracranial portion of the tumor was resected by neurosurgery via an endoscopic and a nasal approach. The dural defect was then repaired with an acellular dermal matrix and nasoseptal flap. Negative margins were confirmed on frozen section. After an uncomplicated hospital course, the patient was discharged and returned to the clinic with no evidence of a CSF leak. After 6 years of follow-up, the patient continues to have no evidence of local regional or distant recurrence. There is currently no further treatment necessary, and the patient will continue routine follow-up for 5 years. Here you can see the patient's post-surgical MRI, showing no evidence of residual tumor.